Hi, I'm Laura Pace. I'm a neurogastroenterologist, and I'm delighted to be talking to you today about non-catastrophic gastrointestinal abnormalities in vascular EDS. I have no disclosures. And so we all know that gastrointestinal symptoms are common in the Ehlers-Danlos syndrome, and this actually includes vascular Ehlers-Danlos syndrome as well. So a very recent study from the Mayo Clinic did a retrospective review of gastrointestinal manifestations in vascular Ehlers-Danlos syndrome. And between 1994 and 2018, they were able to identify 67 patients that met criteria for vascular Ehlers-Danlos syndrome. And 90% of these individuals report at least one gastrointestinal symptom. And so what were they reporting? Well, for upper gastrointestinal symptoms, they reported abdominal pain at a rate of nearly 70%, nausea at 40%, heartburn and reflux also around 40%. It's actually not uncommon for nausea and heartburn to be at about the same frequency because oftentimes the mechanism of these two symptoms is similar. Nearly 30% reported increased vomiting, and nearly 20% complained of significant bloating. For lower gastrointestinal symptoms, patients were reporting constipation at a rate of nearly 40%, diarrhea at nearly 20%, and there was some acknowledgement there is an alteration between constipation and diarrhea for many patients, and this isn't uncommon. Nearly 10% of individuals reported excess straining with defecation, and about 9% reported incomplete evacuation with defecation. And they found that approximately 9% of this patient population actually met clinical criteria for irritable bowel syndrome. And so I'm just going to pause for a moment and talk about functional gastrointestinal disorders, of which irritable bowel syndrome is the most common. So functional gastrointestinal disorders were originally defined to help with designing research studies into the pathophysiological mechanism of these disorders. And the thought was, if we categorize people that had more similar symptoms, we might be studying a more similar pathophysiological mechanism. Unfortunately, over the last many years, these functional gastrointestinal disorders have actually become clinical diagnoses. And I feel like this is unhelpful for our patients because it doesn't allow us to target therapies to the underlying pathophysiological mechanism. So then the comorbid conditions that they identified in this population included nearly 40% reporting some type of allergy. And interestingly, 17% were actually found to have a serum eosinophilia. 20% were reporting chronic fatigue. 9% met clinical diagnostic criteria for fibromyalgia. And then another 9% actually met clinical criteria for autonomic dysfunction. And so something that should be mentioned that we're seeing in other subtypes of the Ehlers-Danlos syndrome is that gastrointestinal manifestations can be sometimes the only manifestation of autonomic dysfunction, even in the absence of orthostatic symptoms. And so this really begs the question, why are gastrointestinal symptoms common in the Ehlers-Danlos syndrome? And I think in order to answer this question, we have to discuss the composition of the gastrointestinal system itself. So let's start with the gastrointestinal tract, which is a muscular tube that extends from the mouth to the anus and is comprised of the esophagus, which is primarily tasked with moving food from the mouth to the stomach. The stomach is a muscular sac-like organ with a very low pH environment. Its primarily function is to actually do the initial food bolus processing. However, it's a little bit more complex than that. And we appreciate this in individuals that have either slow gastric emptying or gastroparesis or bradygastria or fast gastric emptying, like dumping syndrome. And so the stomach actually is responsible for releasing discrete amounts of the food bolus into the small intestine over time. And so this timing is critical to proper absorption of the food bolus from the small intestine, and when not timed correctly, actually leads to a lot of symptomatology. The small intestine is 20 to 30 feet in length in an adult human, and this is really the workhorse of the gastrointestinal system. This interfaces with the other organs of the gastrointestinal system, including the liver and gallbladder, which actually produce and release bile acids, which help with emulsification of fats. And then the pancreas, which releases enzymes, which help with our food breakdown, and also bicarbonate that actually neutralizes the acid produced by the stomach. In the small intestine, this is where the vast majority of macromolecular breakdown occurs, nutrient absorption, water absorption, and actually, very importantly, immune training. The colon is about 5 to 6 feet in length, and while it can, when it's not working properly, can lead to a lot of symptoms, you really can live a fairly normal life without a colon, as its primarily functions are related to waste storage, waste of water absorption, and stool formation that allows us to have waste elimination at convenient times. And now I just want to draw your attention to the right side of the slide. So this is where we're looking at the microbial content per region of the gastrointestinal tract. And what you can appreciate is the vast majority of microbes reside within the colon. And for many decades, this is where the vast majority of research into studying the human microbiota have taken place. In fact, most studies have actually been done on stool samples, as there was an assumption that a stool was an adequate proxy for the colonic microbiota. But two things have actually occurred. One is that we realized that the most important microbiota host interface actually occurs within the small intestine and not within the colon. And secondly, that stool is actually not an adequate proxy even for colonic microbiota, never mind small intestinal microbiota. So then let's get the gastrointestinal tract in a little bit more detail. And so this is actually just a cross section of the small intestine with the lumen being here and then the serosa being here. And so what you can see, I have diagrammed out some microbes that are in the lumen of the gastrointestinal tract. You also would have food particles moving through here. All your medications you take orally are going to move through here. And then there is this all-important mucin layer that's produced by goblet cells that reside within the epithelial layer. And so this is a very important protective mechanism that reduces the interaction of the microbes with the epithelial layer. The epithelial layer is a single cell layer. And it has within it goblet cells, it has enteroendocrine cells, other sensory cells dispersed throughout the entire gastrointestinal tract. One important thing to mention is that the gastrointestinal system has the largest endocrine system called the enteroendocrine system. It also has the largest aggregate of immune cells, and it has its own nervous system, the enteric nervous system. And so it's really a complex organ that is highly regulated for all of its functions. The enteric nervous system is comprised of two plexi that essentially form this mesh network that extend throughout the length of the gastrointestinal tract and are comprised of the myenteric plexus and the submucosal plexus. And so nerve fibers from these different plexi are directly innervating components of the epithelial layer, individual cells within that layer, and regulating barrier function and cellular function. They're also interacting with immune cells that are located within the connective tissue component. They're innervating the vasculature, the lymphatics that are also present within this tissue. Additionally, the autonomic nervous system is directly innervating components of the enteric nervous system, and actually more recently has been found to be directly innervating components of the epithelial layer, those connective tissue immune cells, and the vasculature. And so again, this is highly regulated functions of the gastrointestinal tract by multiple nervous systems. And so this is really important. And so the final point that I want to make on this slide is that the connective tissue within the gastrointestinal tract is integral to appropriate functioning of these complex systems. And so this is just a schematic that demonstrates the the structure of the enteric nervous system and really highlights the importance of connective tissue in organizing the enteric nervous system. And as I mentioned, the enteric nervous system and the gastrointestinal system in general is innervated by the autonomic nervous system. And what you can appreciate from this diagram is every component of the gastrointestinal system is actually innervated by the autonomic nervous system. And the autonomic nervous system is actually communicating with the central nervous system to form what now is recognized as a very important microbiota gut-brain axis. And so this microbiota gut-brain axis is a concept that recognizes that resident microbiota can actually exert considerable influence over host behavior and health. And so when we've sort of reviewed the structure and function of the gastrointestinal system, it's really not surprising that you can have any number of mechanisms that actually contribute to gastrointestinal disorders. So I've sort of broken them down into 4 basic categories. One is mucosal disorders. So these include immunological disorders, including the eosinophilic disorders, but also the more recently recognized mast cell disorders like mast cell activation syndrome. There also can be enzymatic deficiencies, which can be either occurring from defects within the microbiota or actually neurological changes that are altering epithelial cell function. And then really important is this concept of barrier function or permeability. And so the gastrointestinal mucosa is tasked with selectively allowing transport of nutrients across its mucosal layer while selectively keeping out the vast majority of microbes and other toxins that we may actually ingest. There are also other immunological disorders like non-IgE mediated food allergies, which I don't have time to go into detail about, but these are newly recognized disorders that actually are found to account for nearly 50 to 60% of symptoms in individuals who are diagnosed with irritable bowel syndrome. So this is a huge opportunity for more effective therapies for patients. There are also microbiota disturbances and then motility disorders that can either be neurological in nature, immunological, or neuroimmunological. And what we're seeing in the hypermobile Ehlers-Danlos syndrome patient population is that these are incredibly common. And so my recommendation is that really a patient's symptoms warrant a thorough clinical evaluation, but we have to be thoughtful in this, right? So in an individual with vascular Ehlers-Danlos syndrome, there's a concern that there's an excess risk of 9.4% for endoscopic related perforation. And so this means that we have to be performing endoscopy for the right reasons. And when doing it, we have to be making sure that we're doing the right type of testing to increase the yield for the patient and really change that risk benefit ratio. And so that means that we should be implementing mucosal immunological testing for eosinophilic and mast cell disorders when appropriate. We should be considering performing non-IgE mediated allergy testing, which can be done during endoscopy. We can also be looking for other types of immunological profiling when appropriate, and actually collecting samples from microbiome studies, because remember that the small intestine really is the microbiota that we should be concerned about. And then we can also consider motility type studies, but again, we have to be cautious about the risk for perforation. And then also considering autonomic nervous system testing, because sometimes the only indication that there's an autonomic nervous system disorder is actually profound gastrointestinal dysfunction. And so we have to be thoughtful about this. And so in closing, one of the things that I want to make sure to emphasize is that when you're referring your patients to a gastroenterologist for a clinical evaluation of their symptoms, please make sure you're not just referring them to a gastroenterologist who's quote unquote EDS aware. Make sure they're truly EDS knowledgeable, because there are lots of things that we have to consider. And these include even some of the precautions besides just that risk of perforation with endoscopy, but other precautions that need to be implemented when performing such procedures, like making sure that we're considering cervical spine issues, allergic reactions, and even sometimes the need for additional IV fluids. And so with that, I'd like to thank you for your time. And I'd also like to take the opportunity to thank my patients who so graciously share their experiences so that I may continue to learn from them.